Hello, welcome everyone to today's webinar, Implementing SBIRT in Health Centers, Examples from the Field. I'm Tracy McPherson. I'll be your webinar facilitator today. I'm a senior research scientist at NORC at the University of Chicago. I've made my contact information available to you today if you have any questions about this webinar or any of the webinars that we have this year in our series, or if you're interested in getting additional resources about screening and brief intervention that are available through the National SBIRT ATTC or the Brief Intervention Group Initiative, you are welcome to contact me. This webinar is produced in partnership with NORC, the Brief Intervention Group, or the BIG Initiative, the National SBIRT ATTC, NADAC, National Council for Behavioral Health, and SAMHSA. This webinar today is actually launching our 2015 SBIRT webinar series. So we're very excited to get started this year and to be able to offer you a wonderful lineup. We have, as you can see, webinars that are scheduled all the way through August. We hope that you will take advantage of all of these. And in fact, we hope that you will share the information about these webinars with your colleagues, with organizations, partners that you're working with. If you visit our website, hospitalsbirt.webs.com/webinars.htm, you can actually download this flyer. You can also go to that URL to sign up for all of the webinars. You'll be able to access the registration, PowerPoint, and other resources and materials that our presenters will be providing you. As you can see, we have several this year that are focused on adolescents, teens, and young adults, particularly in the college age. This is really an exciting topic for us to be able to offer you a three-part series, and there's so much going on around focusing on adolescents, so it's really timely. So I hope that you will take advantage of that. In addition to that, every year we like to give you an update on the Affordable Care Act and SBIRT, and so again in April we'll be offering that to you. And we will also be focusing this year on working with older adults as well as working with LGBTQ populations and with veterans and active duty. So some really new, fresh topics in our webinar series. We really hope that you'll take advantage of those and download the webinar and distribute those through your newsletters and other places. All of the materials that you will need for today's webinar and for all of the webinars in our 2015 series, as well as those that we have archived for you from the last several years, are all available on our website. All the materials specifically for this webinar are going to be housed at the URL that you see on your screen. Each webinar has its own web page where you can access the information. So if you go to the hospitalsbirt.webs.com website and you click on webinars, you'll see the full list and all the titles, and you can actively click on those to access all of the resources available, including the PowerPoint slides. You are welcome to download those PowerPoint slides, and any of the information is available to you to share and use within your organizations and with your colleagues. Also on those sites, we're going to be posting the CE quiz. We're very pleased to let you know that we're going to be able to offer you free CEs for this and all of the webinars in our series. So all of the information and to access the CE quiz will be posted to the website. And in addition to that, you will find the recording after it has been archived. It will be loaded to the website. It's free education, and the CEs will remain free, and you can access those 24/7. We're going to allow time today for you to ask questions. We have three very exciting presentations today, and at the end of our session, we're going to open it up for questions, and you can ask questions to any one of our speakers. You don't have to wait to enter your questions. You can feel free to put them in the questions box using the question pane over to the right of your screen. And I will hopefully get to go through and take as many of those as possible. If we're able to get some answers to those that we weren't able to address, we will certainly try and make those available, but we will try to address as many as we can. And behind the scenes is our fabulous technical facilitator, Misty Story. She's the Director of Training and Professional Development at NADAC. And if you have any questions or concerns about technology or something you're experiencing, you can put it over into the chat pane over to the right, and she'll be able to try to help you with that. And today's webinar is a three-part webinar, and we are very excited to have National Council partnering with us on this webinar and to have Erin Williams with us today from National Council to talk about the work that they're doing with SBIRT. And so, well, welcome, Erin. Erin serves as the Director of Training and Technical Assistance for Substance Abuse for the SAMHSA HRSA Center for Integrated Health Solutions at the National Council. In this role, Mr. Williams leads the National Council CIHS's strategic initiatives on substance use screening and treatment and provides direct training and technical assistance services that promote primary and behavioral health care integration with special attention to addiction treatment providers. Prior to joining the National Council, Mr. Williams served as the Associate Director of Research and Information for the Danya Institute and the Central East ATTC, or the Addiction Technology Transfer Center Central East, where he was responsible for the management and dissemination of all research related to Institute endeavors. Mr. Williams has more than 13 years of experience in the field of behavioral health services with an emphasis on substance abuse treatment, workforce development, and the use of evidence-based practices in clinical settings. And so we welcome Erin Williams. Thank you, Erin, for joining us, and I will turn it over to you.
Thank you, Tracy, for that wonderful introduction. I want to extend my welcome to everyone on the call today. And it looks like we have a really exciting lineup in terms of discussing issues around the implementation of SBIRT. So one of the things I wanted to do, just to kind of start this off, is really talk about a project that a couple of projects that we worked on at the National Council related to SBIRT. And just to give you a sense of some very general areas of consideration around implementation of SBIRT as you begin thinking about trying to implement this in your health center. Really going over a few kind of key considerations, and then my colleagues on the call here today will go further into depth about some of the more hands-on, day-to-day operational components of implementing SBIRT in a health center. So one of the projects I wanted to talk about was the National Council had the benefit of some grant funding to work with the Coalition for Drug-Free Greater Cincinnati. And in that particular project, we worked with about a dozen or so agencies. These were FQHCs, schools, also community anti-drug coalitions, and addiction treatment providers, helping them as they began trying to work and partner together to implement SBIRT, screening for alcohol and substance use. So through that project and a number of other projects that we've been working on related to SBIRT, we actually have some other grant funding to work with community mental health organizations, helping them implement SBIRT, and a few other projects here at the National Council. We came up with sort of a list of core considerations. And that's really what I want to spend a little bit of time talking with you all about today. So let's get started here. So those three major areas of consideration we want to talk about here are workforce, referral, partnership building, and also workflow development. So with that being said, let's go right into the workforce. So workforce considerations. So many of you are sort of just getting started in terms of implementing SBIRT. And one of the things you have to make some decisions around is the workforce. So who is going to be the person that's implementing your screening protocol? Who's going to be the person that's providing your brief intervention? And who are the people that are going to be coordinating care or engaged in the referral to treatment process? So with that being said, some of the things you want to think about related to workforce are, the types of providers. So one of the core considerations you have to make is who you're going to use to provide screening. Let's say, as an example, are you going to use doctors, nurses, behavioral health staff, other specialists? Really, it's a very contextual decision. There are a number of different places across the country, and in our experience, that have gone very different routes with this. Some, they use doctors to provide that level of screening. Others, nurses, nurse practitioners, and others, much lower level staff, looking at sort of behavioral health specialists or even community health workers who are doing that initial kind of screening. Now, much of this is really dependent on, what are the billing and reimbursement concerns within your state or municipality, who is actually reimbursed for providing these services. There are a number of different folks who are reimbursed for these services. So it really depends on sort of what your billing mechanism is, in what state you live in. It also depends on what the skill set is of those particular providers. What is their licensing? What is their credentialing? Are they credentialed or licensed, in a way that allows you to be reimbursed? And do they have the proper skills in terms of training and expertise to deliver these particular services? So there are a number of things you want to think about here as you begin to look at this concept of who provides that initial screening. And again, the same thing applies when you think about who is going to do the brief interventions or brief therapy, depending on how you set up your SBIRT protocol. One of the things you want to think about is, if you're looking at implementing SBIRT in the FQHC setting or in a health center setting, is that you're dealing with a much shorter time frame in terms of delivering these services. And all behavioral health therapists may not be accustomed to working in the short, more fast-paced environment that a health center is going to provide. So you really want to think about who you place in these roles. Some therapists are very used to providing services in a 50-minute session. If you are implementing SBIRT or providing some sort of brief therapy, you won't have anywhere near that long to provide services. So you really want to take a look at who you put in those positions and how they relate to working in that fast-paced environment. Other consideration is in a health center environment, you probably are going to be working with clients who may not be coming in, with any thought of having a substance use disorder or any sort of issues related to alcohol or drugs. They're probably coming in for some other ailment, some other disorder or condition. So you really want somebody that's going to be very skilled in talking with them and working with them, given the context in which they are presenting themselves in the health center. So you certainly want to have someone that has a skill and understanding of chronic health conditions that may be related to alcohol and drug use. You also want to have people who have some level of skill in terms of working with people who may have some issues with alcohol or drugs, but may not necessarily meet the criteria for abuse or dependence. May be having more problematic use or use that is inappropriate given their underlying health condition. So you really want to think and really be strategic, about who you place in these roles and what particular knowledge or skill set they have. So definitely having some level of knowledge of the relationship between substance use and other health conditions is a critical piece. Not only the other skills as it relates to providing brief therapy. So knowing knowing the motivational interviewing, having some skills in motivational interviewing, enhancing motivation, in brief cognitive therapy or other things that may be considerations as you look at the workforce. So one of the other things you want to consider here as you begin thinking about the implementation of SBIRT is partnership development. Now, if you look at a lot of the data related to SBIRT, I think you'll know that at the most, probably about 20, at the most 20% of the folks who come in who screen will need some sort of referral to specialty treatment. Although it's not the majority of folks who are coming in who need to be referred to specialty treatment, there will be some who will meet that criteria and need to go on to further services. And as a function of that, you want to make sure that you have the resources and appropriate partnerships and connections, for that particular referral. In our experience working in the Greater Cincinnati project, one of the main issues and concerns there, with a lot of the health centers in terms of implementing SBIRT was the fact that health centers were not particularly knowledgeable about, where they could send folks who needed additional treatment for substance use disorders. They didn't have good resources in the community. They didn't have good partnerships in terms of working with behavioral health providers. So they really didn't have the level of knowledge and communication between their community partners to really fully develop their service delivery array in order to make those appropriate connections. So that's really one of the things you do want to definitely think about. You want to really examine sort of what providers are in your network. What services do they provide? Like, do you really know what are the levels of service that they provide? Do they provide intensive outpatient services? Do they provide residential services? Do they provide medication-assisted treatment? You really want to have a good idea of what those community partners do. How well you work with them. Are they? Do they have a backlog? Is there any way in which they can prioritize your clients? You really want to have a good sense of that. You really want to take that knowledge you have of those community providers and ensure that your staff, the staff who are working with clients, have a good understanding of where to send clients or where to triage clients that's most appropriate. What those resources are. You also want to have and engage in some careful consideration around who's going to do the coordination between the two agencies if you're referring outside of your own agency. Are you going to do or set up some sort of electronic protocol within your EHR? Are you going to use some sort of care coordinator? Is that going to be work that's done by your behavioral health staff person, or are you going to set up some other sort of protocol or mechanism? Because one of the things you really want to consider there is how you do that, because that's critical to ensuring that people who need a level of service actually get to the services that they need in order to effectively engage in treatment. Another issue that came up in our experiences is, literally that people would get a recommendation for or referral to treatment, and there would be no real follow-up, no real communication between the health center and the provider, and they had no idea whether or not a client ever actually reached the referral that they were given. Or clients would literally go downstairs, walk out the door, and you wouldn't hear from them again for 6 months, and you had no idea whether or not any of the problems that were cited were being resolved. So you really want to pay attention to who is coordinating that care, who is following up, and you also want to make sure that you have a good communication mechanism between your agency and the wherever you're making a referral, whether that's internal or external. If you're using the EHR, then that's one thing that makes things much more seamless. But even within that, you want to make sure that you have policies and procedures in place that allow for you to seamlessly share information back and forth. You want to be able to know whether or not a client showed up for treatment. You want to be able to get some information back and forth about the client's in care or not, or what happened with the client in order for you to enhance your service delivery the next time you see them for their primary care appointment. So you really want to give some good information on how information is going to be shared, set up your back-end protocols and procedures related to that. That'll be critical as you think about developing those partnerships in order to appropriately triage clients. So one of the other things that I think, I'm not sure if folks really understand, and in order to really implement SBIRT, one of the things that you're going to have to do is engage in what we call the workflow analysis, which is really sort of a detailed look at how clients navigate your current system of care. So how a client goes from sitting in the waiting room all the way through to receiving healthcare services, potentially receiving a screen for alcohol and substance use, and then all the way through into how they're referred out for treatment. So you really want to sit down with your team and really take a good hard look at examining this, even going as far as to take a walkthrough. In a number of the projects that we've worked on here at the National Council, we have encouraged providers to have one of their staff or one of their clinicians to actually do a walkthrough. So actually go in and go into the center just as a client would, and really go through to see kind of what happens at what place, where do you go to have a screen provided, who does that screen, what happens next, who talks to you about it, how long does it take between receiving a screen and then having a brief intervention. Does someone talk to you about a referral if that's necessary? How long does it take from the initial screening and brief intervention to receive that referral to treatment and actually go to that referral to treatment session? So you really want to develop a real, a serious workflow of what it is that's happening currently, and then what it is that you want going forward as you begin implementing SBIRT. One of the things that happened is that many of the organizations we worked with, they thought they understood what was happening initially, but when they actually started doing a more detailed, workflow analysis, they found that they actually, didn't have some pieces correct in terms of what the agency and how staff were actually working with clients around certain activities. So you had to actually go in and sort of modify the workflow, based on what was actually happening. And then you make the changes necessary to move forward and implement your SBIRT protocol. And once you do that, you really want to get that down on paper, have a detailed chart in which everybody sort of agrees on this is how it currently happens, and this is what we think is the most appropriate for it to happen going forward. And really, document that and have those policies in place. So those are three of the major considerations, at least, from our work with SBIRT, that you really want to look at. Those three areas of workforce, referral to treatment, and then also doing that workflow analysis to make sure that you have those protocols in place. One of the things, before you get started, I wanted to make sure that you all, really went through the whole process. That you want to do is you want to assemble a team that's really going to be the group that's really going to help push forward SBIRT and implement it within your particular agency. I know there's a lot of talk and discussion about having a champion and having someone that's sort of responsible for pushing it forward and being that champion inside the organization and moving it forward. And yes, that's true. You definitely need to have that champion within your agency and moving it forward. However, you really want to, in order to get the sort of spread and hold of SBIRT as a protocol within your agency, you want to get the buy-in of the entire agency. So you want to have a planning team that really involves different levels of the agency. So if you're a behavioral health provider that's kind of championing this or moving this forward, as a part of your planning team, you really want to have, some higher ups, maybe there's a medical director or a doctor, some administrative staff, so someone in the C-suite, whether that's the chief operating officer or someone at that high level that really can become a part of a planning team and help you as you move forward with implementing this to really let everyone in the organization know that this is a change that's being endorsed and we think this is the right thing to do, and then move forward with that process. And you also want to have some more line staff and others that are part of that planning team as well. And with that team, kind of the core areas in which that team needs to work is, spending some time, selecting the screening instrument, taking a look at sort of what are the major concerns in your health center in terms of what sorts of illnesses or what sorts of chronic conditions you're beginning to see in the health center. What do your doctors say is sort of the most pressing behavioral health problem? Is it alcohol? Is it substance use? Is it depression, anxiety, or even trauma? And then looking at the appropriate screening tools that examine those particular issues that are of interest to your organization. Maybe you want a much more broad screening tool to use, which is fine, or you want something more specific. But that planning team is really going to be part of the group that's going to be the group that's going to really work on selecting that particular tool. As we talked about, definitely considering things around that referral, that system of care. What is your system of care? They'll be helping you with that workflow analysis. Also, one of the things they'll be doing that's critical is really looking at the communication loop and the documentation of all of this. Because once you engage in this planning process, once you sort of go through this iterative process, you put something out, you make changes and tweaks based on what happens in real time. You want to have some way to document all of this and to have it codified so that when there are transitions in the team, or people leave, or switch agencies, or other changes happen, others who come into the organization can step right in and continue the work that's been done. You also want to look at how you're collecting data. Part of this, implementing SBIRT and pushing this forward and improving clinical care is that you're going to have data coming back out of this about the types of substances being used, the types of behavioral health issues that are going to be of major concern. And you want to be able to take that information, figure out what you need to collect that information, and then push it back to staff in order to help inform clinical care. You definitely don't want to collect this kind of information or get this sort of, data around SBIRT and not actually use it to improve clinical care. It may, help you, as you consider what sorts of resources and services that you want to provide at your particular organization. If you want to, provide a 12-step or recovery coaching or some other sort of, service. These are the kinds of things that you would look at. So definitely consider, data collection and data collection methods and how you communicate about that data. Again, the comprehensive policies and procedures are going to be, necessary for this to be effective and for it to have some lasting power. Also, staff will need some sort of training. It's very rare that you're going to find people who walk in who are going to have all the skills you need all the time. You may need to set up, trainings, where you're going to go for those trainings, who in-house can do those trainings. You may need periodic refresher courses around screenings or around brief interventions, motivational interviewing, other sorts of techniques. So definitely that should be a consideration for that planning team. And then, you also, this is certainly important. You want to discuss the billing and financial implications of what you're doing. That should be woven into any discussions around implementing SBIRT. How are you going to be reimbursed for time and services, around these things? You want to improve care and you want to be able to move these forwards, but you don't want to, do that, in a way that's going to, hurt you fiscally, because then that may impact your ability to provide any sorts of services. So you really want to take a look at what those billing implications are as it relates to all of the work that you're doing. And also, you do have to understand that this is a continuous quality improvement project. So if there are changes that need to be made to your original plan, that's fine. If you have to tweak something, it's okay. You just want to be consistent about making those corrections, continuing to improve, and then re-examine it to see if if it's working the way you want. You definitely don't want to implement something, not change anything, for the next 5, 6, 7 years, And then you get down the road and you wonder why you have all of these policies and procedures in place and no one, there remembers why they were in place. You really want to be sort of a constant, continuous quality improvement process in terms of implementing this. It's okay if it's not perfect the first time. You want to continue with that effort and then move it forward. So these are kind of the core considerations that we've learned from the work that we've done here at the National Council as being critical to the implementation of SBIRT in any health center or really any agency. To be quite honest, that we think these things are pretty critical and some things that you may want to pay attention to as you move forward. And now I want to turn it over to my colleagues here who are going to discuss more in detail and give you some more examples of SBIRT as they implemented it in their own particular health centers. So thank you for your time.
And thank you, Aaron. Thank you for sharing that information. That guidance is just so on point, and a lot of the folks that are on this call are, may have been doing it for a while and haven't thought about some of these things, and some are very new to doing it, and I think all that guidance was really spot on. So thank you so much. National Council has a lot of expertise in this area, and I really appreciate you coming on and sharing some of that with us today. If folks are digesting this and thinking about what's going on in their own organization or want to get started or wherever they are in that continuum of implementation, as part of the National SBIRT ATTC, the work that we do in providing technical assistance and training, you're more than welcome to email me. If you're interested in getting some technical assistance by email or telephone, I'd be glad to set up a quick call with you, and maybe I can help troubleshoot or provide you with some resources. My email address, which is at the beginning, and I put it also in the questions pane. There's already some great questions coming in. You're welcome to email me, send me some dates and some times, and I'd be glad to talk about your individual needs. So I can see your presentation, Aaron, is already stimulating some good questions and some thoughts about what people are doing in their own organization. So thank you. And now we're moving on to part two. Part two is we're focusing on SBIRT at Southwest Virginia Community Health Systems. And I'm really excited to have Marcy Rosenbaum on our webinar today. I interviewed Marcy, I don't know, several months ago, and had the opportunity to come and visit Marcy and her staff at her site out in Southwest Virginia in Saltville, precious little town in Southwest Virginia. And I was really excited to see what they were doing and really had the opportunity to see how it was working and to hear the story of how it unfolded and the challenges and how they worked together to do it. And so it's really a pleasure for me to have you, Marcy, on the webinar today to share your experiences. I think many people can learn a lot from what you've been doing. Marcy is a behavioral health director for the Southwest Virginia Community Health Systems. And the community health system there in Southwest Virginia operates 4 federally qualified health centers, FQHCs, with the purpose of providing primary care services to rural Southwest Virginia utilizing an integrated primary care medical home model. Her credentials include she's a licensed clinical social worker, a certified substance abuse counselor, and has a master's in social work from Radford University. She is the Behavioral Health Program Director. She's a trainer and a provider of behavioral health services. In addition to her expertise with integrated behavioral health care, she has a wide range of experience, including a clinical social worker in a state psychiatric hospital for patients with substance abuse and or mental illness, and an alcohol and other drug abuse specialist for residential school and training program, and employment and detox units, substance abuse treatment and prevention programs, and with child protective services. She's been a trainer and a presenter for local, state, and national organizations, including Radford University, National and Virginia Associations of Social Work, and the Mid-Atlantic Telehealth Resource Center, as well as the Virginia Community Healthcare Association and Virginia Healthcare Association. So I'm going to turn it over to Marcy. Thank you, Marcy, for joining us.
Well, thanks, Tracy, for that introduction. I really feel like somebody now. I'm very, very grateful for this opportunity to share our work here at Southwest Virginia Community Health Systems. And I really hope that some of our peers out there can benefit from our successes and some of the challenges that we've had. Let me see here in just a second. There we go. Southwest Virginia Community Health System, just a little bit about our agency. In 2011, we were a HRSA nominee for Best Practice for Integrative Healthcare Services. We have the 4 clinics. We have also a dental clinic, and we're staffed with behavioral health consultants. There's 4 of us. We're all LCSWs. We recently were able to hire a psychiatrist that rotates between our 4 clinics. We have 2 dentists, an eye doctor now, and of course our primary care providers, and we also have a migrant health outreach worker program, and I'll speak a little bit to that a little later on. As I go through how we use SBIRT in our agency, I think it's important to understand the benefits of integrating the behavioral health and the primary care together, which is the model of care that we've chosen to use at our agency. There's basically one overall service delivery system, which is our 4 FQHCs. And the behavioral health care and physical health care are merged together so that we can treat the person as one whole person. In this case, behavioral health care includes both the mental health and the substance abuse. So why would we even integrate behavioral and physical health care? First of all, most psychiatric treatment is provided by non-psychiatric medical providers. Also, 70% of primary care appointments are related to psychosocial issues, and usually seeing their primary care provider is the first point of contact for mental health and substance abuse issues. So we're in the trenches. Also, approximately 1 out of 4 patients will actually make it to a behavioral health appointment if they're referred outside of that particular agency. So we feel like integrating services into our agency helps increase the patients accessing those services. There's also less stigma and discrimination if a patient is going to a primary care office as opposed to going to a mental health clinic or a substance abuse care facility. And another issue is adults with any mental illness are certainly more likely than adults without a mental illness to have chronic health conditions, and so providing all of it in a one-stop shop. A couple other issues. One is it helps reduce the burden of care. The burden of care for mental health patients is often greater than our mental health services can provide in our communities. They're just overburdened with the number of people that are in need of the services. And also from the primary care point of view, they often don't have time to address the mental health issues. They get 10 to 15 minutes to see their patients, and that includes taking care of all the issues that they bring to that appointment. So it makes it difficult for them alone to manage those mental health concerns. Funding and access is an important issue. With the Affordable Care Act, there's more grant opportunities out there for integration of services. Also, some third-party payers now are offering incentives to integrate. And one of my favorite issues is location, location, location is so important for services. And in general, it just brings better outcomes. It's more cost-effective for the patient and society through lower long-term health care costs. One of the basics is it costs less money to transport yourself to one facility and get all your services there in one day. It can be more efficient, more effective, And also simultaneous treatment, again, of those co-occurring disorders increases positive outcomes. So I want to spend a minute talking about the complexity of intersecting diagnoses in integrative care. So most of the patients we see don't come with just one issue. They don't come with just high blood pressure, and they don't come with just high blood pressure and alcohol abuse. In most cases, patients will bring an average of about 6 different ones. Now that's a pretty complex patient, but that is actually an average patient that we might see, especially here at our healthcare center. And certainly our primary care providers need and very much appreciate the support that they receive from our behavioral health consultants. Now the integration of substance abuse services themselves into the primary care setting have several treatment benefits as well. Some of them are screening can identify your high-risk substance abuse behaviors that your patients have and help target your prevention of developing a substance abuse disorder. Integrative treatment is a preferred and evidence-based model of care. It can bring a substance abuse expert into the treatment plan quickly. Here at our clinic, we do exam room consults, which means with the behavioral health provider here at the clinic, if there's a substance abuse issue that comes up, we can be brought in right there in the exam room. And also, it can specifically identify withdrawal or overdose issues that may need some outpatient or inpatient treatment if you have a behavioral health consultant who is trained and educated about substance abuse issues. And the impact for our patients can be tremendous. It can reduce psychosocial distress, prevent further illness, or slow the progression. Often it can be described with integrative care as a one-stop shop, kind of like the super Walmart. But basically, you can go to one place and get all your services. And in our area, being so rural, it's very difficult for folks to get places. And so if you can go to one place and get all your services, you're more likely to come, so it increases the amount of services that people are going to receive. To the patients, we can identify behavioral health issues and diagnoses that may otherwise go undetected. There's, again, the less stigma, timely access, and just improving the overall health of the patient. Now I'm going to shift to the specifics about SBIRT and how we use them in our agency. The purposes of SBIRT is a model of service delivery, not a specific technique or a program. It's an early intervention approach, and again, as we talk about patients making their first point of contact at the primary care office, it's a perfect place for early intervention. Aimed at people who may not meet diagnosis level of abuse or dependence. And also, you want to be sure you're using evidence-based practice to identify, reduce, and prevent problematic substance use. So how do we use this SBIRT at Southwest Virginia Community Healthcare System? And I'm going to go over each of these. We've got screening, brief interventions, referral to treatment, and I'm going to give some example of use in our integrated system. So screening being the first part of SBIRT, here we use the AUDIT C. It's embedded into our electronic record system. There are many others that can be used, but with SBIRT you need to be sure that you use a standardized assessment or screening instrument. Also use the SASE. We always use the biopsychosocial assessment as well. There's just some that can be used. Here's a closer look at the AUDIT C. We complete it once a year on all patients. So when they come in as a new patient, we do an audit C, and it's repeated if the patient is referred to the behavioral health consultant, or if, again, once a year, and if there needs to be a further assessment. After an audit C, we will go to using a FACI sometimes, or just a psychosocial assessment. But the audit C is our first point of screening for patients. Here's a snapshot of our initial behavioral health screening. As I was listening to Aaron speak, I noticed several things that we are doing, a few things I wish we had done. So here's an example of the flow of services. When a new patient comes in, the nurse does a PHQ-2, which is a depression screen, and an audit C screen. So we embedded the SBIRT screening into our initial health assessment that we do with all our patients. Again, looking at the whole person and including that in our health assessment. If either of those screens are positive from the nurse, there's a recommendation for the patient to see the behavioral health consultant, and hopefully that same day. If those screens are negative, then the primary care provider continues on with the examination. And if there's any indication during the examination of a behavioral health issue, again, there's a referral. Sometimes they may screen negative, but all of a sudden there's these physical symptoms that could be related to substance abuse, and then a referral is initiated at that point. Well, one of the things that we worked through was what was the best way to refer a patient to a behavioral health consultant. It can be a very stigmatized type of referral, especially in our rural area, for any type of mental health or substance abuse services. So the way that we address this is in the exam room, the primary care provider will introduce a behavioral health consultant to the patient as part of their treatment team, and as the expert that they use for behavioral health issues. Then the primary care provider leaves the room, and the behavioral health consultant will conduct the consultation. They'll talk with them about their symptoms and connect it as much as possible back to their medical issues. And it's seen as the best practice, best referral method for integrative care when schedule allows. We think this process does a really good job at helping the patient see the behavioral health person as connected with the primary care provider. Now, most any substance abuse treatment tool that's used in traditional mental health or substance abuse treatment can also be used as a brief intervention, usually in a more brief format. Here's some examples of the ones that we use at our clinics: motivational interviewing, cognitive behavioral, some relaxation training, relapse prevention planning, trans-theoretical model of change, one of my favorites, harm reduction, and others. And I would like to say that anyone from my era who was trained in substance abuse, harm reduction was a very taboo subject because we wanted people to be completely abstinent, but that was the best way. And I heard Aaron refer to the context of the screening is very important. And in our context, first point of contact in the primary care office, they may not be at the point of dependency or abuse, and we want to really engage with the patient and start with what their goal is, what they want to be different about their lives. So in harm reduction, you want to meet the person where they are, what they want to be different, what their goals are, reduce risky substance abuse behaviors, help improve their mental and physical health, which if the mental or physical health is not doing well, they can increase the chances that they might use, so we want to work on those as well. And use any evidence-based intervention that seems to meet what the patient is needing at the time. Now, when do we refer folks out for treatment? Basically, referral is made if a patient's needs are greater than can or should be provided by the practitioner. Some examples might include the intensive outpatient. Our community services board in this area provides a more intensive program, some group therapies, case management services for patients that might need those, inpatient treatment. Overall, if their needs are greater than can or should be provided here. And an example of should be provided, for example, I'm an experienced person in medical detox and long-term treatment, but the clinic that I work in is just not set up to provide that for patients and to provide it in a safe manner. So that's a service that I'm not going to provide here. If they need that service, then that's probably something we're going to refer a patient out to. And most referrals are done by our behavioral health consultants in conjunction with the care managers that we have at our facilities. Now, building our SBIRT team. One of the things to keep in mind is that all our practice decisions flow from a medical home model of care. And a medical home model of care is best described as a philosophy of primary care. It's very patient-centered, comprehensive, team-based, coordinated efforts, accessibility, and focusing very much on quality and safety for the patient. Collaboration is key. Now, in building our team, we have licensed or certified mental health or substance abuse specialists. In our case, we use currently 4 LCSWs. You want to be sure that you have someone that can bill for those services in the agency. Screenings can be done by non-licensed paraprofessional healthcare providers. They have, according to Medicaid, they have to be supervised and recommended by a primary care provider when done in a healthcare setting. In our agencies, the initial screening is done by the RN or the PCP. And further screening is done by the behavioral health consultant. Interventions really can be done by all of us, and most referrals, again, are by the behavioral health consultant. If there's any question, I think it's really important to check with your payer for specific qualifications of providers so that you can continue to get reimbursement so that you can continue to provide services. I do know of some folks who've utilized students who are in educational programs to become licensed mental health providers. Sometimes grant funding can provide for that. But for long-term sustainability in our agency, having a provider who can bill for that has helped us stay successful with it. Some info about the SBIRT reimbursement codes, things to keep in mind. They can be used for reimbursement with Virginia Medicaid and Medicare, some commercial insurance carriers. That varies sometimes by the day. There are several different billing codes that can be used, and often you have to check with the payer. Credentialed behavioral health providers and medical providers can actually both use codes on the very same day. Same-day services also require a modifier by the payer to signify that it was a separate service. You can also use SBIRT with telehealth services. GT modifier is necessary for that. I think the Mental Health Parity and Addiction Equity Act has helped with our reimbursement so that we can continue to provide more services for our patients. So here's the magic numbers we use at SBCHS. The SBIRT codes here, we use usually the 99408 and the 99409. They're time constraints of 15 to 30 minutes. We usually use that when we're using an audit C, and sometimes with the brief interventions, and if it's greater than 30 minutes, we, of course, use the 99409. This is normally used only by the behavioral health consultant. It would be unusual for a primary care provider to spend that much time with the patient on that one particular issue. One of the things that we found is by bringing in a behavioral health consultant to provide those services, it reduces the amount of time that our primary care providers have to spend in an exam room with the patient, so they can move on to other patients in the workflow of our setting, and the behavioral health consultant can be the expert and take care of the substance abuse or mental health issues. So in our workflow, there's a new patient that comes in. There's a health status exam that includes a screening, in our case an AUDIT C. It can be positive or negative. If it's positive, we're going to refer to the behavioral health consultant. We can use either of those two codes I shared earlier. Then they have their first visit for further screening or intervention with our behavioral health consultants, and follow-up visits as necessary. And sometimes it's determined that the needs are greater than we can provide, and we refer them to some outside support. If the screening was negative, then they just continue on with a medical exam. So some tips from the field. So these are some challenges that you might find. Stigma, I think, is one of the biggest ones. With substance abuse, there's often quite a bit of labeling, some shame, which can prevent access to treatment. Again, I think integrating services in the PCP office helps tremendously with that. Lack of resources, always a problem, financial. In FQHC, we have an income-based fee scale for our folks who don't have insurance. Even those that do have a hard time usually coming up with their co-pays. There's a lack of providers in the area, so finding folks to fill our staffing positions. Transportation, in our rural area, there's no buses that go around that you can catch to go to the mental health center. Usually it's a neighbor with a car that will go that far. Infrastructure. When Tracy McPherson came to meet with me, I think we really zeroed in a lot on the importance of infrastructure. A lot of facilities, primary care facilities, were made, of course, to have exam rooms and set up for a primary care provider. Now, with the integration of services, location is really, really important, because to coordinate services the best, the closer you are to each other, it makes a huge difference. I know my own caseload more than doubled when I located from an office in the corner away from the primary care providers to being right in the middle of their workflow and next to their exam rooms. It makes a huge difference to have eyesight with someone that you want to just pull into an exam room. And also one of the challenges is there tends to be a disconnection of services. In this area of the country, integration is a fairly new concept, and we tend to compartmentalize everything. Some folks get into turf issues, and services can just be uncoordinated. Another tip, I think, is it's key to educate staff. I was glad to hear Aaron talk about the importance of educating all staff. We take an opportunity at most staff meetings to speak to behavioral health issues and substance abuse issues. One of the key questions that I like to address with our staff is substance abuse a voluntary or a medical disorder? And my answer to that is yes. It depends. There is a continuum of disorder. In the beginning, it's usually voluntary. Very quickly, though, like a bicycle going downhill, it can get to a more complex medical disorder. And when you get into the dependency of substance abuse, the ability of the person to exert some self-control can become pretty seriously impaired. So as health professionals, we like to catch them up in the voluntary area as soon as we possibly can with those early screenings. Here's a list of some resources that you can look through if you get the slides. I've used all of these on several occasions. Of course, the World Wide Web, where most of these you can find. Often Google has the best answers if you filter through it really well. Here's some programming ideas. Of course, I'm a big believer in the integration of physical and behavioral health care. This includes, we have the same treatment plans with the behavioral health consultants as the primary care provider. It's one plan. Our offices are located together. We use the same records. And we can be very interruptible. Doctors can come and interrupt a session, and I can go make a very brief contact with the patient and do a warm handoff. I can also interrupt the doctors. I can knock on the door, let them know I have a particular issue with the patient, and we can take care of it that way. We work together as a team. Collaborating with other agencies and providers, we try to meet with our community services boards in our areas to be sure we're coordinating services, helping each other out when we can. Telemedicine is an option. We've used it a few times here and continue to. Collaborating with educational institutions like I talked about, and again, educating all staff, not just the healthcare providers. I want to spend the last few minutes talking about some of the special populations that we see at Southwest Virginia Community Healthcare System. The folks out there will probably see a lot of these as well. We have dual mental health and substance abuse diagnoses, chronic pain patients, patients with ADHD, adolescents, and our migrant health population. Sometimes all these at the same time. In terms of dual mental health and substance abuse diagnosis, treatment integration is key. This includes substance abuse, medical, and mental health, looking at the whole person. Each disorder can improve or worsen the other. They're comorbid. Treating one disorder while ignoring another, in my opinion, is a disservice to the patient. It's important to treat all their issues. And truly, that would be near impossible for a primary care provider to do without the support of behavioral health consultants. Managing co-occurring disorders, all as being primary in regards to treatment planning, can be helpful. And it's just the best treatment for the complexity of all those intersecting diagnoses. To give you a field example, there was a patient brought in to see the doctor, and the complaint was he won't eat and he's losing weight. When the primary care provider was talking with the patient, turns out he's a well-known alcoholic in the community, and he was refusing to talk to the doctor. They thought he was just being obstinate because his wife brought him in, and then he wouldn't talk to anybody. So what would happen next? Well, without the behavioral health component and the substance abuse component, probably not much. But in our case, the patient was sent to me for substance abuse issues and cognitive screening. I found that there was no recent alcohol use. This was confirmed by the family. I did a mini mental status exam, and it showed some pretty significant cognitive dysfunction. He also had some paranoia. I talked to the primary care provider, and they sent the patient to the ER in case there were any medical complications that were having such a severe impact on his cognitive skills. Ultimately, he was diagnosed with psychosis and depression, and Wernicke syndrome was discussed as an option, but we worked together on the diagnoses and sent him to specialists as needed. Now he's eating pretty well, his wife says. Chronic pain, addiction to pain medications, is a never-ending concern for our medical providers. Many times I've had to explain to patients the delicate balance between managing their real pain and avoiding physical dependency on pain medications. You have to really be able to demonstrate an understanding with their need for pain relief while also helping them become aware of the risk of leading into a dependency on the medication. It can be quite the balancing act. I think for providers, it's important to remember that often alcohol, and especially back in the olden days, was used for pain relief. Patients often use alcohol or street drugs to relieve a true medical pain condition that they're having. Remember, they can become dependent even if it's a prescribed medication. A lot of folks don't understand that I've talked to here at the center. And consider using pain management centers, which we do a lot. And in our centers, our behavioral health consultants augment a lot of the pain issues by teaching relaxation techniques and new coping skills to reduce body tension. Anxiety disorder and ADHD medication, in general, they're not good for the addictive brain. We try to use alternatives as much as we possibly can. However, there will be times that it's indicated. Severe PTSD patients, anxiety that keeps somebody from going out of a house. So if a person has a substance abuse disorder or a history of such, you have to do a lot of monitoring to be sure that they're staying on track and also getting their needs met. With adolescents, engagement skills are key. If you can't engage with the adolescent, you've lost them. SASE adolescent screening can be helpful, including parents, while providing as much confidentiality as possible for the patient. That can be pretty tricky. Don't be afraid to use drug screens. Look for associated behaviors. And certainly don't forget about the inhalants and the designer drugs. I had a grandmother bring her son to me one time. She couldn't understand why he had all these paper bags with gold paint in them under his bed. Look for all those associated things that might be related to that as well. And our Migrant Health Network, Chad Brown is our coordinator of this program, and I'll talk with him some about special needs for that population. Migrant Health Network provides basic health services for migrant and seasonal workers here in Southwest Virginia. They're at risk for health problems due to many factors, including lack of transportation, lack of knowledge about resources, lack of resources, language barriers, always a problem, and their mobile lifestyles. Migrant workers often also come from a culture that has an acceptable tolerance for heavy alcohol use, and so education is important with that population. And often our migrant workers in this area leave their families behind, and so there's an increase in depression, a decrease in support systems, and an increase in overall substance abuse related to that. So at the end of my slides are some of the references that I used, and now I'm going to turn it back over to Tracy.
Great, Marcy. Thank you so much for sharing your experience and telling us about what you've been working on for some time down in Southwest Virginia. It's my pleasure to move on to the third part of today's webinar, and I'd like to introduce Scott Turton. He is currently Director of Primary Care Integration and Electronic Medical Records Implementation for Gosnell on Cape Cod, a multi-site addictions and mental health service on Cape Cod. He received his MSW from Wilfrid Laurier University in Waterloo, Canada, and interned in both hospital and community health settings before accepting a position as a clinical director with a regional center for HIV/AIDS care. Prior to relocating to the U.S., Mr. Turton had been involved in community-based research, developing whole language systems for children with autism, EAP, that's Employee Assistance Programs, and also maintained a private practice. In 2001, Mr. Turton relocated to the United States, where he was accepted a position at Gosnell on Cape Cod. In addition to provision of direct clinical services for both mental health and substance abuse patients, he has presented on substance abuse trends and services, supervises clinical staff, and is involved in the development of Gosnell's program, Integration of Behavioral Health Care and Primary Medical Care. So it's my pleasure to welcome you, Scott, and it's nice to see you on this webinar. We had the great fortune of meeting your colleague, Mr. Tomasi, a couple of years ago, and really saw your what you're doing as a real hot spot in SBIRT, and so we're really glad to have you. So I'm going to turn it over to you now.
Thank you so much, Tracy, and thank you to my my colleagues who presented previously for great presentations. My presentation is going to take a little bit of a different track. in regards to looking at the relationship between two separate organizations and how that relationship came together in order to provide an SBIRT service model for delivery. So a standalone behavioral health organization, that's my organization, Gosnold, and an FQHC. One of the goals of this presentation is to demonstrate that there are particular advantages to this type of organizational collaboration when using an SBIRT model for managing SUD patients. So just to give you a little bit of background on these two organizations, Gosnold is a multi-service organization serving the needs of Cape Cod and southeastern Massachusetts. It provides services geared to populations managing substance use disorder and those managing mental health conditions. The service structure for the organization includes inpatient, outpatient, community-based services, and integrated services in a variety of medical settings. Gosnold operates a 50-bed medical detox, an inpatient rehab facility, 2 residential facilities, a number of transitional homes, 7 outpatient clinics, a school-based counseling program, a recovery coaching program, a family outreach program, a community-based prevention program, a telepsychiatry program, and a medication-assisted treatment program which focuses on opiate-addicted SUD and includes an outpatient detox program. So it's a fairly wide range of services offered by the behavioral health organization. Gosnold serves over 12,000 individuals a year within our service continuum, and we reach far greater numbers through our various community-based programs and integrated services. Harbor Health, or FQHC, is a federally qualified health center operating a number of sites serving Boston, South Shore, Massachusetts, and Cape Cod communities. The network of health centers includes 4 health centers and also includes an elder service program, a WIC program, and a community dental center. Harbor is a medical home for more than 26,000 patients and a family dentist to an additional 10,000 patients. So that sets the groundwork for the 2 organizations that came together to look at establishing a service model, in this case SBIRT, to provide services to the FQHC patients. So negotiations for this relationship took place over a relatively long period of time. It was about 2 years of discussions between the 2 organizations. These were direct discussions between the CEOs of both organizations. As Tracy just mentioned, Mr. Ray Tomasi, who's the Gosnold CEO, has been involved for a number of years forging various relationships with area medical facilities as he has seen that integration of behavioral health services into primary care and medical settings is a trend and an important development for healthcare generally. So he's brought our organization in line with that focus. The CEO at the FQHC was also looking at establishing something that was going to be an innovative practice. He, at his other clinical sites, not at this one that we were integrating with, had traditional behavioral health services, but he was experiencing wait lists, problems in communication internally with staff in regards to the behavioral health services, so he was looking for something quite different. So the 2 organizations entered into discussions to provide something that could be considered innovative and also would better serve patients in the setting. So negotiations took place for this to happen, and this particular fact is interesting with these negotiations. So both were looking at providing something for patients, and Gosnold, as the behavioral health organization, had something very unique to offer in this relationship. We not only could provide the behavioral staff to staff the SBIRT effort, we were also able to provide access to substantial outpatient clinic nearby the FQHC, access to a consultations on the prescribing of psychiatric medications between the clinic medical staff and Gosnold psychiatrists, and streamlined access to inpatient facilities for SUD. So these were things that the behavioral health organization brought to the table, which were very interesting, of course, to the FQHC. And it's also worth noting that as Gosnold moves forward in establishing our telepsychiatry program, that would also be extended to the FQHC for both consultations with the medical staff in the FQHC and possibly to even provide telemedicine as a site within the FQHC for their patients. So those were things that the behavioral health organization Gosnold brought to the table. Okay, and as in any relationship, it takes work, and it's sort of like a dance on some level, and that's why you see that picture of two people dancing. I could not find an updated picture. These people look like they're probably from the 1940s. There was a picture of a mosh pit, but I didn't think that would be applicable to our situation, so I did not put that one in. So what are some of the factors that are important here for relationships if you're bringing two organizations together to create SBIRT? Motivated and determined senior management is absolutely essential, and I just mentioned some of the background on that particular piece. Dedicated resources. Now this is also a pretty important aspect in order for this to be a successful endeavor for the organization. So the behavioral health organization, Gosnell developed a department with focus on integration efforts. The staff was involved in collecting data on integration efforts, which it utilized for quality improvement and for research grant applications. The organization dedicated financial and staffing resources to participate in substance use disorders learning community through the National Council, which helps us refine our efforts in structural design of our integration efforts, use of SBIRT as a core element of structuring treatment, and developing financial sustainability. Harbor came to the table with huge need for behavioral health services. The FQHC had been using PHQ-9 to screen for depression, but when scores indicated a need for further evaluation of treatment, the patient would be referred out to treatment, would often sit on a waiting list to receive treatment from the referred organization, would sometimes not be referred out because medical staff were too overwhelmed with current duties or felt that referring was a useless exercise. So the FQHC was very motivated to try something different. FQHC was assigned their Director of Behavioral Health to work with Gosnell staff to fully integrate behavioral health services into their site. This individual was extremely knowledgeable and understood the level of integration and pushed for full integration as the desired model. So relationship dynamics. We look at various aspects of this relationship as being very, very important, as I've mentioned in this previous slide. We had contract negotiating by the management teams, and this was about staffing. This is about time on the site with the behavioral health staffing from Gosnell, how the staff would be integrated into their teams, and reimbursement structures between the two organizations. Just to note the picture, I must apologize for that. It looks like this woman is trying to drag this man into the ocean. That is not symbolic of what we were trying to do here. It was actually supposed to be more of a picture of two sort of dance type of relationships going on the seashore, which is really all about Cape Cod. So a little bit of a strange coincidence with that picture, so I'd ask your apologies for that. So behavioral health staff was integrated into one of the medical teams in July 2014 on a part-time basis. That staff from Gosnell became a contract staff of the FQHC, so had full access to their EMR and full security access to their facilities. The Gosnell BH staff and the Harbor staff worked together in setting up the SBIRT structure, and the previous presentations actually, if you refer to those when you get the slides, you will note that what we did between Harbor and Gosnell was very similar to the previous presentation in regards to having medical staff do the screening, behavioral health staff consults, and referring on from that point. The FQHC took the lead in applying for funding under MASBIRT. Actually, that should be MASBIRT. It's a state program in Massachusetts that provides training, education on SBIRT, and also funding for training your staff. So all of the FQHC medical staff were trained in the SBIRT model. That is actually ongoing as we speak. and the Gosnell BH staff moved recently from a part-time position to a full-time position integrated into their services. This next slide I'm not going to spend a lot of time on, as it's been covered in the previous presentations, but we talk about who performs the screening, the handoffs through the EMR. Oftentimes, when I was actually, as I was a behavioral health consult staff in the FQHC, I would receive people through my schedule in the EMR or by a WARM handoff, being asked to come directly into an exam room. My services at that time were recorded as consultations and were brief in nature, and the patient was bridged to an external service if needed by or indicated by the results of the screening. Okay, this slide, again, you will find this core competencies. This is an exceptional list of attributes that you will be able to find in SAMHSA, on the SAMHSA website, and you'll see the reference in the next slide of where you can look at it. This is actually the core competencies or characteristics of a successful behavioral health consultant working within an SBIRT model. So I'm not going to go over these individually. I'm just going to point out a couple of important things here. Screening and assessment. And there has to be an excellent sort of background in screening and assessment, brief screening, particular, brief assessment, particular. And also down to number 7, a systems-oriented practice. This is incredibly important for a behavioral health consultant working in the SBIRT model, because systems-oriented for those clinicians in the audience means that they're looking at all aspects of the patient's environment, from physical health to mental health to substance use to spiritual health to community supports, and looking at how all of that fits together for the patient to be sort of moving through not only their current systems, but the medical system in which this all takes place. So the last core competency, informatics, is really about how the behavioral health consultant uses information from the EMR, information that's already in the EMR, or information from Google, as is noted in this little cartoon here, to help them inform decisions, care decisions, help them sort of provide educational materials for patients in a very quick, rapid environment in which the consultant is operating. And you'll see there's the reference for the SAMHSA article on the core competencies. So lastly, just to review this very, very quick presentation, success factors when two organizations are coming together. These are the things that I've mentioned in the presentation: motivated FQHC who has a need for behavioral health services, internal staff spearheading the effort, specific training programs for SBIRT, has been noted in both previous presentations today, behavioral health consultant with core competencies, behavioral health consultant facilitating access to services, particularly in our organization, that the FQHC benefit from a multi-service organization focused on substance abuse and mental health as the collaborative partner. So the behavioral health consultant, being part of both organizations, was able to provide enhanced access to all of the available community services for those individuals who were considered to meet the criteria for being referred outside of the SBIRT model. And finally, the BH organization that is knowledgeable about integration and models of integration and has leadership buy-in is an important factor for success of this entire model. So that is my presentation, and I'm going to turn it back to Tracy.
Great, thank you, and thank you for experiencing, sharing your experiences that you've had at Gosnell, and so I appreciate all of our speakers today sharing in a very condensed form a lot of very rich information that I can see from questions and comments people are really benefiting from from what you're able to offer today. Part 4 is really questions from the audience, and I've been busy answering some questions and providing resources and links, and so folks can take advantage. I've posted them to everyone, so feel free to read through those and use those for your purposes. I know there's some duplication in some of the questions, but I'm trying to answer as many as I can. I think what we'll do is open up for a couple of questions. We're coming very close to the close of our webinar. We will take the questions that don't get answered, that either the folks on the call are not able to answer, and if we're able to get answers for you, we will try to do that and make those available on the website where the PowerPoints are. So there's a couple of questions that came in for you, Marcy, about the model that you were using. Also, Aaron, there was a question that came in about use of Medicaid managed health plans. It looks like that person has actually not had to step out. But what we're going to do is, if we can gather that information from you, we'll forward you that and get your response. I didn't see any other specific questions for you, Aaron. But Marcy, let me find one for you here. This person would like to know if your group has a BHC working all hours in the clinic when it's open.
At each clinic, we have a full-time behavioral health consultant, and sometimes our clinics do work later till 7 o'clock. So it varies by each clinic. We have one BHC that works 4 days at one clinic, 10 hours, but it's not every single hour that the clinic is open.
Okay, and what happens if a patient refuses to talk to the behavioral health consultant?
That certainly is up to them, and it depends on the situation as to what we might do in that regard. Sometimes the primary care provider will make seeing me as a condition of prescribing certain medications due to the educational component and watching for symptoms and working on relapse prevention planning. So always, it's a patient's choice. They can utilize our services or not. But part of my job is to help educate them as to what those services are and leave it up to them.
Okay, great. And are you currently billing for those services? There's several questions on whether you're billing or not.
Yes, we are billing. I put the couple codes that we usually utilize in the slide presentation that I gave, and that's what we use.
So you are billing. That's great. And yes, it looks, and Scott, looks like we have a question here that came in when you were speaking. Let me find it. Where to go? Are nursing homes in New York able to do SBIRT and be paid by Medicare and Medicaid? Do you know that?
I do not know, because I'm in Massachusetts. I'm not sure whether there would be regulations in New York that would allow that to happen. I know in Massachusetts we're fairly good about getting that type of those codes paid through any organization, any facility that uses them. So I'm not sure what the issue or the answer would be for New York, though.
Okay. Well, we'll see if we can get some answers to some of these other questions. Sorry we weren't able to get to many of the questions. I have done many of them behind the scenes, so I hope folks will take advantage of that information. And I wanted just to close down and our presentation today, and just to remind folks that on our website is all of the information about today's webinar, PowerPoint, our CE quiz, a recording. The free CEs will be offered following your completion of the CE quiz. And one of the things I would really like to ask you to do, there's a link over in the chat pane for the SurveyMonkey, which is a brief, short evaluation form. It's really essential, very critical to maintaining our funding, that we get your responses. It's very, very brief, and it really allows us to bring you the quality education that you were provided today and in the future. So I can't stress enough how important that part is. And you'll be receiving a follow-up email that will cover all of the information about how to access all of these things. In addition to that, I just wanted to remind everyone about the wonderful webinar series. Thank you, everyone who have been on the call to launch this series. Please go to our website, download the flyer, register. They're all open for registration. We look forward to having you on future webinars, and we thank our partners very much for their participation, the folks on this call, National Council, SAMHSA, NADAC, and of course the National SBIRT ATTC. Thank you, everyone, and please join us for the remainder of our 2015 SBIRT webinar series. Have a good day.